So, today, as you're aware, we're going to be discussing a palliative approach to major neurocognitive disorders. And just to save the word jumble in my mouth, I will be referring to it as dementia throughout this program. So, I have no disclosures to provide. And then for today, an outline. And honestly, if there is something else that you'd rather discuss, then certainly as a group, by all means, we can stop and work through some scenarios if there are things that are coming up in your workplace. So we're going to review dementia, go over the diagnosis and the daunting question of, well, how long are they going to live? The trajectory of dementia and issues regarding our clinical practice. So, things that come up in the research as being clinical dilemmas are certainly differentiating between dementia, delirium, and depression. Having an appropriate pain assessment and interventions. Advanced care planning. What does that look like with someone that has cognitive impairment and engaging the family within the long term care setting? Artificial nutrition, what appropriate prescribing may look like, and transfers to the emergency department. So, no surprise to you that 72% of our residents in long term care have moderate to severe cognitive impairment. And Alzheimer's disease is the second most prevalent medical condition within long term care, with the third being a dementia other than Alzheimer's disease. Any guesses as to what number one is, just for giggles, honestly? Just kind of keep my eye on the chat. All right. Well, number one is actually hypertension. So just for fun. So for residents without a diagnosis of dementia, the Canadian Task Force on Preventative Healthcare recommends against instrument-based screening for asymptomatic older adults. So we know that even though dementia is quite common within the residents that we do service, that we do get folks that do not have this diagnosis. So just a reminder not to screen. So for example, on admission, doing a cognitive screening test. However, within the long-term care setting, certainly there is some data that is collected based on the quarterly assessments and the admission assessment through RIMDS. And for other homes, it will be going to InterRI. Oh, arthritis. Thanks, Ben. That was a good guess. So some of this data will be related to RIMDS. I know that some homes are in transition or have transitioned over to InterRI, but what they have is the cognitive performance score. And it has been validated against the mini mental state exam. And what this chart illustrates is through the data that's already being collected within the long-term care setting, what the average MMSC equivalency would be. So in making the presumptive diagnosis, so according to the DSM, there should be evidence from the history and the clinical assessment. That in itself, you may be gathering, if someone comes into long-term care, that may be a discussion both with the resident or their family members, as well as the frontline staff. So certainly they may be able to, after getting to know the resident a bit, be the ones that you may get some of this history from in order to recognize dementia. And so from this history and clinical assessment, that indicates a significant cognitive impairment in at least one of the following areas. So it's either learning and memory, language, executive function, complex attention, perceptual motor function, or social cognition. And you need to also identify that the impairment has been acquired and represents a significant decline from a previous level of functioning, and that this is interfering with their daily activities of living. And what also needs to occur is that you've ruled out a delirium, and we'll talk about that in future slides, and that it's also not related to a mood disorder. So, really piecing together, is it dementia related, is delirium, or is it a mood disorder that is ultimately causing this decline? I'm only going to touch upon 4 types of dementia, as opposed to there are several other diagnoses with cognitive impairment, but these are the 4 that we'll touch upon tonight. So, with Alzheimer's disease, we all know that it's the most common type of dementia, and risk factors, certainly as we get older, our risk increases significantly. So, the incidence rate doubles every 10 years after the age of 60. And for folks who are diagnosed with Alzheimer's disease with an early onset, it's related to a genetic mutation of the amyloid beta precursor protein. And if this mutation exists, then there's 100% risk that there's 100% like you will be getting early onset Alzheimer's disease. And the hallmarks of this change is that there's the diffuse plaques related to amyloid beta deposition. So, and then there's also the neurofibrillary tangles. So, from the tau protein, they become more hyperphospholytic and result in an accumulation of those as well, leading to an inflammatory state and then ultimate um, atrophy of the cerebral matter. For vascular dementia, if someone comes in with a diagnosis of vascular dementia, just be aware that based on autopsy findings, that only 10% are true vascular dementia alone. It typically goes hand in hand with Alzheimer's dementia. So identifying it as a mixed etiology. And with it, it's any major neurocognitive disorder that is primarily caused by cerebrovascular disease or impaired cerebral blood flow. So, how do you identify this? Well, you've clinically diagnosed them as having a stroke, and then we're seeing the signs of dementia. Or based on the brain imaging, there's been an identified vascular brain injury in a patient with dementia, but without a clinical history of stroke. So you may have done imaging for whatever reason, and it's one of those findings a part of the scan. So Lewy body, with Lewy body dementia, there needs to be at least 2 of the following. So 60 to 80% of these folks have cognitive fluctuations, and about 70% have visual hallucinations. They have sleep concerns. So one of my residents, for example, she's acting out something from her past while she's sleeping. And then Parkinsonism. So at least having 2 of those. These other supportive clinical findings are quite common, but are not part of the diagnostic criteria. So these folks are hard, are hard to manage some of the BPSD accompanying it. So antipsychotic sensitivity, they may and so, for example, the side effect of having orthostatic hypotension, they're more sensitive to the antipsychotics. So, titrating in order to manage, for example, BPSD becomes challenging. Syncope, their instability of falls, hypersomnia, hallucinations and delusions, and then apathy, anxiety, and depression. Now, with frontotemporal dementia, it's a common cause of early onset dementia. So it actually has a similar prevalence between the ages of 30 and 50 as Alzheimer's disease. So it is quite, if it's for early onset, then very, very prevalent. It's characterized by prominent changes in social behavior and personality, or aphasia, so the loss of the ability to understand or express speech. And this can be further broken down into the three clinical presentations. So we have the behavioral variant of frontal temporal dementia. Um, so some folks, I when I'm talking with personal support workers trying to explain why a resident is behaving or the way that it is, unfortunately with the frontal lobe, that's our social filter, right? So when our social filter is impaired, then certainly we may see the loss of inhibition. So they can have these changes in their social behavior. Then the other two forms that are related to aphasia, we have progressive aphasia, so the ability to express speech, and then the semantic variants. So they're having difficulty with the understanding and meaning of words. So how do we answer that question? That question of, okay, so they have dementia and it's progressive, but how do how do we say how long that they have? I know that we were just talking about prior to this presentation about, well, being in a transitional care unit or being in palliative care or hospice beds, and they seem to be getting better, and how to navigate this. It's tough. It's tough because as we're seeing through the trajectory, the challenge is that there is not this quick decline. Even when we're looking at um, the, we're looking at years of general decline, and then over months, and even as they're approaching death, like you could be looking at months. And the other piece among our folks that this graph doesn't take into consideration, so it's certainly related to dementia, but so many of the residents that we see have multiple comorbidities. So even though that they have dementia, this is the typical trajectory. If you have CHF, COPD, all of these other comorbidities, when you're trying to explain to a family, can make it very complicated. So certainly there are these periods of decompensation, but they may not be as evident or as significant as COPD or CHF. I know I have, so there are family members who regularly want to touch base with me regarding where they are in regards to where they are in their dementia journey, and things fluctuate a little bit. They may decline a little bit, but then they may have a bit better days. But overall, when we talk about reflecting back over the past few months as opposed to what the resident was like a year prior to, then this paints more of the picture. I honestly, this one can certainly be challenging, and I know that as part of, like, for example, what I put on a death certificate, if someone has ultimately died from dementia, is related to malnutrition due to not refusing to eat or drink as a result of their dementia. So that is one of the indicators that I really try to coach families on when they are asking for, well, when can I expect them to be transitioning into end of life, or when we're having those discussions. Okay, so dementia certainly presents unique challenges in end of life care, including difficulty defining the transition to end of life, as we just talked about. and communication challenges, determining the appropriateness of medical and palliative care interventions and integrating that within the long-term care setting. Because, for example, like in long-term care, we may be limited to, for example, you may have certain lab days, or so Life Labs or whoever that your service provider is may come in. For example, I have labs on Wednesdays and Fridays, and certain days we may be able to do phlebotomy ourselves, but don't let anything go wrong after 1 o'clock because no one's coming to pick up the labs. So there certainly are logistical challenges within our setting, and also the they're advocating for time and how to integrate these conversations into our workflow. So as we go through these next sets of clinical practice, I want you to think about, well, how is long-term care already set up? How can we integrate some of these pieces if you choose, and how that can work, because certainly time can be difficult, and how can we collaborate with our interprofessional team in order to shift to a culture of a palliative approach to care. But as a result to all these challenges, we know that suboptimal end-of-life care in dementia exists, such as inadequate pain control, overuse of medical interventions, and care that's inconsistent with what the resident would have wanted if they were making those decisions for themselves based on um, previous wishes. And ultimately, this leads to unnecessary suffering and ethical challenges. So, in these next upcoming slides, we'll talk about differentiating between dementia, delirium, depression, a pain assessment, advanced care planning, and artificial nutrition, appropriate prescribing, and transfers to ER. So certainly it's heavy loaded. So we're gonna probably just skim the surfaces on a few of these topics, but at least I'm hoping that I can give you some resources in order to somewhere to start. So I'm sure this slide is very familiar to quite a few of you, but um, certainly when family comes to you, or the personal support workers or the registered staff, and sometimes the complaint is they're more confused, and really it can be um, all of these things, or our job really is to try and piece together what we need to tackle. So, as a review, certainly dementia is a very gradual onset, and the course, as we went over the trajectory, very stable, predictable, and the features are memory loss. And with delirium, it's a rapid change, and uh, certainly I recommend that delirium be considered, because what may happen is there's both hyperactive delirium, so we have to figure out the underlying cause, but there can be your hyperactive delirium, right? Where these folks um, are very, like, they're hyperactive, they have their very, like, certainly it can be very apparent that there is a change in them, and it's quick and it can fluctuate, and there's a lack of attention and concentration. But what is difficult is when there's a hypoactive delirium, because um this may not there may be even a delay in reporting that someone is more withdrawn or quieter, and sometimes it's mislabeled as, well, I think that their mood is in that may staff may come and say, I think that they may be a bit depressed, but ultimately there might be a medical cause for that delirium. Now, as for depression, onset typically gradual, weeks to months, and it may ultimately affect cognition. So the thing is that none of these happen in isolation, so that's where it is complicated. And I know in my own practice, I I do a lot of delirium workups. I do just to make sure that I'm not missing a piece if it aligns with the goals of care. So, for example, I may speak with a family member or the substitute decision maker if the resident lacks capacity, and I'll disclose what is going on. That we've noticed this change in the resident, and that I talk about that it could be these 3 things if it's not clear, and then have, the delirium workup completed in order to see where we are currently at. And sometimes, as you may know, some people and I always find out what their goals of care are, discuss about where they're currently at, review what they previous discussions with goals of care are. So certainly within your home, like ensure that there's a easily searchable documentation setup. So I know point click care is very prominent. So certainly we have a heading that is goals of care so that you can just run that so that you can see exactly what the previous conversations have been. And those conversations are not just with me, but by our registered staff as well. So that when they're documenting it, I can look back and be like, "Oh, okay, well, you spoke with this nurse before, and this is what the goals seem to be. And right now, this is what we're seeing. It may be due to a underlying medical cause." Um, and then just reflect on, is this appropriate to investigate or to treat? So the experience hopping over to pain, certainly the experience of pain is complex. And with with so certainly we have our physical causes of pain, but also these folks that are moving into long-term care are experiencing significant loss. So they've relocated. This may either be a positive experience, they may be happy with this decision, or but ultimately it is a shift in their life. And also for their support network, the relationships that they have may also be changed. Certainly, moving into long-term care may be a financial stress. So there certainly is a charge living in long-term care, and maybe they're uh, leaving a household that they shared with their spouse, and then finances are divided in order to support this bed. So there's many factors that influence the experience of their pain. And I would argue that in long term care, this is oversimplified into how we collect data on pain control into the pain assessment. And even though, because what it really relies upon, right, is that the staff and the team that we're working with identifies and appropriately reports, and that this gets into the system, into the charting system. So certainly we're relying on PSWs and our registered staff working with an individual who may not be able to or may have difficulties communicating their experience with the pain. So in long-term care, the pain scale is what's reported to CHI high, and as the numbers increase, 0 being no pain and 3 being the most, we can understand why that pain may be undertreated because we're probably under-identifying it. And when we go through nursing school and nursing school and training to be clinicians, we discuss about how to take an appropriate subjective um, history, and we're using our OPQ or STUV. And when we're doing that, we're talking to someone who has the ability to reflect upon, well, when did this pain start? When, what helps it? What makes it worse? Like how do you what quality does it have? Like, is it sharpening? And even though when we're working with cognitive impairment, that can be impaired. So then so all the tools that we have in our toolbox that we're typically taught going through training can certainly be impacted. So, certainly, dementia may impair their perception of pain, the reporting of their pain recall, and the recall of their previous treatments that they have tried or what has worked well. Sometimes coming into long-term care from their previous settings, the history it can be difficult to gather this information. What they've tried over the counter, was it appropriate? Was it effective? Um, how long has the pain been going on? Sometimes it can be very difficult in order to pull all that information. But and sometimes you may find out that when you're doing a review that they're not eating as well. And that may ultimately, based on your investigation and collaborating with the staff, that, well, they're not eating as well because and they're not accepting food because they actually are experiencing some dental pain, and that connection there sometimes may be missing. So certainly it's a team approach, and it's not as straightforward as going to the resident and doing an interview to identify their sources of pain. So for pain assessments, there's ultimately no gold standard. Certainly there's, even though there is a significant importance for accurate clinical pain assessments, the literature is mixed regarding which tool is the most helpful. Um, Ultimately because of the limited research validating the tools and within this population. So in the next slides, I will show you the Pain AD if you're not familiar with it, as well as a facial grimacing scale. And depending on who I will um, s- certainly utilize, and we do train both personal support workers as well as the registered staff in the utilization of these assessment tools, because ultimately, like, for us to be able to do this, it doesn't make sense because we're not with them all of the time. We can't track when this pain's occurring and gather all of that information because ultimately we're not with them 24/7. So it's certainly a team approach. So with the pain assessment in advanced dementia scale, so these are for folks that certainly do not have, cannot recall their experience with pain or may have difficulties expressing their cause of pain. Okay, so hopping over to advanced care planning. So um, I'm just going to encourage you. So we have Jim here. He's an 82-year-old, and Jim has moderate to severe Alzheimer's disease and COPD. His palliative performance scale is at 40%, so he is getting out of bed, but he does need frequent breaks, needs some help with his ADLs, but he's eating well, and pleasant, like pleasantly confused. And he is in a COPD exacerbation, and you're unsure of how aggressive to treat him and whether or not to transfer him to acute care should he decline. And Jim is a widower. His two adult children live out of town, and his two siblings live in town and visit regularly. Jim's sister says, do everything to keep him alive, and his brother says he has had enough, keep him comfortable. Uh, how do we approach this situation?
Do we know whether Jim has a designated POA?
Good question. So no, he does not have any POA documents. Good stuff, Julia. Oh, I saw the whole space there. Good. So that's the first start, but actually that's the second piece. So the first thing is who should we be chatting with first or evaluating first?
I'm gonna guess Jim.
Good job, Julia. That's not a guess. So Deb, certainly we need to consider capacity. And this is just to hammer in the fact that even though you have a diagnosis of dementia or major neurocognitive disorder, that does not automatically make you incapable of making any decisions. So capacity certainly does need to be assessed. So does he understand and does he appreciate the consequences of making this decision? And certainly in long-term care, what we know is that capacity long-term care, as well as with the trajectory of dementia, we know that at some point capacity in making these decisions as to where care is going to occur or what the goals of care are. So it's when we're looking at symptom management or withdrawal of treatment, all of these things are going to be coming up um, in the future, like now and in the future, but involving both the resident. But I would recommend that if they are deemed capable, that either yourself or the nurse review the discussion with the substitute decision maker, uh, just so that, and during setup care conferences, like if they're at their post admission or if it's their annual or if things are changing or if it's requested and there is a care conference set up, ensuring that these conversations have occurred, or if there isn't the capacity of the resident, how you frame that conversation. So certainly I I advise the substitute decision maker that it's challenging. There will be certainly I ask them, like, how did you discuss with Jim prior to this, um, what what he valued, what he thought would be his priority, what kind, knowing everything that you know about Jim, if he was here today to make a decision based on how he is currently and what we see in the future with his COPD, with his progression of his Alzheimer's disease, and trying to frame pieces like that so that it almost takes the burden off of the substitute decision maker if it's a reflection of essentially that's their role, right? To be the proxy to make a decision based on what that individual would have made if they could do so. Um, it's that's how I try to frame it, because sometimes when someone calls, and this is what I'm trying to coach both our nurses here too, certainly at my home end, is how to navigate these conversations so that so that a conversation isn't, oh, they're deteriorating. Do you want to send them to hospital? Like the way that you frame these conversations, painting what previous goals of care discussions have happened, reviewing the trajectory where we're currently at, and what Jim has expressed that we may know, what has he expressed to you, so that when they're making that decision, it both alleviates hopefully some of the burden from that SDM in making that call, and also so that the treatment decisions going forward or withdrawal of treatment decisions going forward are focused on what Jim had expressed and reviewing the impact of hospitalization. Perfect. Okay, so in this Cochrane systematic review, they found that advanced care planning interventions with people with advanced dementia probably increase the actual documentation of uh, their advanced care planning plans, and and also increases the number of discussions about goals of care. And that's really not surprising. So they may also, there may be a slightly increase in concordance with goals of care. So hopefully, even though that we're doing these advanced care planning, it's important to, recommending that there's either a reflection if the individual isn't able to engage in advanced care planning, depending on where they're at with their cognition uh, uh, when they do come to your long-term care facility, that encourage the family member or the substitute decision maker to reflect on those previous conversations um, so that they are able to, based on the education that we're providing, the coaching that we're providing to nursing, so that when we're having these conversations that we're all framing it in the same way to direct it back into the goals of care for that resident. So integrating this into the long-term care setting, I got a little ahead of myself, but certainly advanced care planning and long-term care, there are some built-in structures based on the Fixing Long-Term Care Act that we need to consider. So upon admission, it's identifying who is the substitute decision maker. Some of this are basic, but I wouldn't say that necessarily they're basic. Sometimes I have residents who are admitted in and they don't want to identify a substitute decision maker in the event that they don't have capacity, and they'll flat out refuse. So, um, in those situations, it can be difficult, but at least if the nursing staff knows who to contact, and ultimately, if there is absolutely no one, then looking at the public guardian and trustee decision support line in those instances, if they still have capacity to make their own decisions regarding certain aspects. Reviewing goals of care with the resident and the substitute decision maker. So there's the 6 week post admission care conference. And certainly within that period of time, I do a lot of education on the trajectory of disease with regarding dementia, where they're currently at, what we can forecast, how the other comorbidities also play into the role, and ultimately trying to get also discuss like what their goals would be or what their expectations are, reaffirming like what so if what is realistic within the setting of long-term care, and finding out like from a symptom comfort management standpoint, um, is that what they're hoping for, or are they coming in and the expectation is, well, they're going to go to emerge like every time that they look at me sideways. So it's trying to figure that out and really find out where you're starting off with, and discussing the trajectory. And it's more of an interview with them as opposed to looking through the chart and starting to spew everything at them, but find out what they know about where their loved one is at, or the resident knows where they're at, and what they're anticipating in the future, and what their hopes are regarding as they go through this trajectory. Um, and certainly all of this should be documented and easily searchable so that you can refer back. And ongoing, the goals of care are periodically revisited, and certainly with significant health changes. And what I really encourage is promoting a goals of care culture. So this involves conversations are held routinely, both with the the resident and the family member, but also with the frontline staff, because I find that even though there's such a high proportion of our residents with dementia, um, some of my staff, or sometimes they almost seem shocked that someone died, or that someone stopped eating and ultimately died. with this diagnosis. And I think that we shouldn't just presume that everyone understands this trajectory and what to anticipate as someone approaches end of life as a result of dementia. So certainly providing education to registered staff and personal support workers to both gather information, but also to prepare them as to what the forecast is so that um, they can both support each other as well as be a better support to the resident and the family members because they're the first line of contact. As for resources, this is a very small picture, but this is from Ontario Health regarding palliative care resources. So there are advanced care planning links here, and certainly the slides will be shared with you so that you're able to access some of these advanced care planning options. Also, what else do I have in my toolbox here? So the waiting room revolution, they have a roadmap, and this is for residents and substitute decision makers. So it's for any setting. It's not specific to long-term care, but it certainly provides an opportunity to review the trajectory and then prompts whether the resident or the family member themselves about what questions to ask. And it also reviews like what stage they may be at as they progress through dementia. When we're looking at advanced care planning, so this is through the strengthening a palliative approach in long-term care. So um, they have a toolkit, and within it, they have advanced care planning, and this is a resource for residents and substitute decision makers of a conversation guide, because they may move in and there may be an opportunity where certainly the substitute decision maker can have these conversations, but they're going to be like, how do I even bring this up? Like, or you don't know where to start. So this is an option. All right. So as for artificial nutrition, so we have Lori, and she's been living at your long-term care facility for the past 4 years. She has severe cognitive impairment with a diagnosis of mixed Alzheimer's and vascular dementia. The registered staff have been recommending a pureed diet due to recent episodes of choking to her son, who is also her power of attorney. Her son approaches you and requests for a feeding tube as he believes that no texture modifications, oh, sorry about the typo, will eliminate the risk of his mother choking to death. How do we handle this? Goals of care. Like it can be difficult for families to to struggling to watch their loved one lose the associated weight when ultimately the body's preparing to die with dementia, and that does impact the drive to eat, and uh, it can be difficult for someone to watch this. So honestly, they're projecting their own experience of hunger to an experience that that individual is not experiencing. And we certainly do need to have these open discussions about change in the feelings of hunger and the drive to eat as dementia progresses. And it's something that needs to be prepared, that they need to be prepared, and this should be discussed as part of like as you discuss the trajectory of disease. This should certainly be a component linked in. So here's a plug from Choosing Wisely. So what they recommend, don't insert a feeding tube in individuals with advanced dementia. Instead, assisting the resident to eat is what's recommended. And the reason for that is that tube feeding can cause fluid overload, diarrhea, abdominal pain, and discomfort or injury. And it can actually increase the risk of aspiration and aspiration pneumonia. So, helping people eat rather than food than tube feeding is certainly recommended. Okay. So, what I am going to skip a little bit. um, just because I am cognizant of the time. So, um, potential harm. Here we go. Okay. So certainly, many of our folks or many of our residents may be started on anticholinesterase inhibitors or memantine, either by yourselves or prior to admission. And just a reminder of deprescribing.org to review the algorithm as to how to appropriately taper and potentially discontinue. Certainly, there's been updated guidelines on BPSD that have come out that certainly do support the utilization of ordering these medications earlier on in mild to moderate dementia, but certainly when we get to a state where they're in an advanced state of um, cognitive impairment, then the indication is not required, or if they're seeing a cognitive decline despite being on therapy. Now, this one I just learned about yesterday. It's always good to learn from other folks. So, medication stopper, there's an option to select for frailty or for cognitive impairment. So it's called Med Stopper, and what you can do is you can add their entire medication list. And I was picking on lorazepam because why wouldn't I? And then what it does is it provides you with a printout and it develops a plan, including a tapering schedule for you to consider for reduction in medications. So, if things are okay, so for example, I had my make believe resident on donepezil, and it they didn't meet requirements for deprescribing, so everything go ahead with it. But for lorazepam, it gives the indications as to why this may not be an appropriate medication and then provides a tapering. But of course, all of this is said in having consultation and collaboration with the resident and the family member for buy-in. Oh, here we go. So certainly transfers often result in long periods in an unfamiliar and a stressful environment for the resident. And other hazards including delirium and hospital-acquired infections, medication side effects, lack of sleep, and rapid loss of muscle strength while being bedridden in this setting. So often the harms often outweigh the benefits. And I saw that coming up in the chat as well, that this was identified in our previous case regarding advanced care planning. So residents assessed and treated in their home, such as long-term care, will certainly receive more individualized care, better comfort, and end-of-life care. And if the transfer is unavoidable, then please do give clear instructions and 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 realistic expectations as to what the outcome may be. So this is also a statement from Choosing Wisely. So certainly prior to any transfer, that there should be a goals of care discussion. And certainly we've changed um, part of our practice in order to support our nursing staff, where um, if there's time, if there's like, and most of the time there is, that they would give our medical team on call first, give a call first prior to immediately sending to emerge, just so that we can review potential diagnoses, what we can offer within house, and also talk about if they need some coaching or mentoring as to what may occur as a consequence to a transfer. Um, I'm saying this as though I'm not in the facility, but and so that they can be supported in their discussions with the family member prior to deciding where the appropriate care can be provided. Okay, you made it to the reference slides. Any questions? Seeing some tips and tricks in the chat. Thank you.
I just think I gave a put in the link to we had a session a couple weeks ago on food and nutrition at the end of life and long-term care. And I think one of the things that came up, and might be something for us to talk about down the line, is people said it would be really nice to have some sort of a resource to share with family or substitute decision makers about like the decreased need for food and nutrition as somebody is dying, because oftentimes they don't understand that, and like you say, they're thinking with their reality of hunger and that kind of thing. And so, but we don't have great, like, aside from verbally conveying that information, we don't have great tools to help teach that information, I don't think.
That's a great point, because our emotional response and our connection with food is very strong, absolutely very strong. So, um, yeah, having a resource for the family to refer back to, because just after one conversation, it's something to support them, certainly, because some people may buy in right away to that, but um, yeah, definitely a support. I think that some places have made their own, but I don't.
Anyway,
don't-
there was we had the presenter was a dietitian from the Pearly, and so thanks for that connection, Ben, and we'll have to, I think just I think it'd be a fun project to work on down the line.
In a funny way, it's interesting that uh, the way that they die almost matches their appetite. It's it
I yeah,
with all with each trajectory actually.
so true.
Last
I
call
guess
for
that'd be cutting to the chase, eh? In those goals of care conversations, that'd be just cutting to the chase for that.
yeah.
I mean, I talk about the change in appetite. I call it cachexia. Um, right at the initial care conference and at each and every care conference afterwards. So that we don't get the resistance from families, and at the same time the families get a sense that, yeah, okay, my mom, my dad is dying.
Mhm. Mhm. Yeah, and I think that framing it, that it's not just memory loss, but that that the body is preparing to die with this diagnosis, and that this is exactly what we anticipate to see as this body is preparing to die. And absolutely the cachexia is part of it. And then I think the capacity piece is is an area that we can certainly work on developing. Um, because I think that recognizing that capacity in our setting, there's almost a knee-jerk reaction, well, we're going to call the POA or we're going to call the whoever the substitute decision maker that's listed, but assessing capacity and recognizing, hold up, do they have the ability to appreciate and understand is sometimes almost overlooked once you see that diagnosis of dementia on a chart. And yeah. All right. Well, I want to thank you. Thank you so much for participating. And I think next month, Avel, it's on neurological
Yeah, we
disorder.
have Woojin Kim from the Palliative Cell Clinic at the TOH, who's going to be coming and talking about palliative care for people experiencing a variety of neurological conditions. So hopefully we'll see folks then, and hope everybody is shoveled out of their, reality wherever they are in Eastern Ontario, because I don't think anybody was spared. And thanks once again, Rebecca. We really appreciate you doing this.
Thank you. And everyone stay safe and warm.